Hello, my name is Emily Rich. I'm an occupational therapist and I practice in the clinic in Tucson, Arizona. I work part-time working in the clinic and part-time doing research. And I specialize in seeing individuals with the types of diagnoses that you're going to see in your IPE event soon. So these are individuals with hypermobile Ehlers-Danlos syndrome or hypermobility spectrum disorder, as well as postural orthostatic tachycardia syndrome, POTS, and mast cell activation syndrome. We often call this the triad. These diagnoses many times go together. And not only do I see these individuals in the clinic and get to do research in these populations, but I also happen to live with these conditions myself. And so my hope is that you are going to see really just so well highlighted how interprofessional education is is necessary, and interprofessional teams, multidisciplinary teams, are just essential in the management of these complex individuals. You might not have heard of some of these diagnoses before. You might not have heard of any of these diagnoses, but I can assure you that um, in your career, if not within the first couple of years, you will see at least one of these folks, and likely you'll see many of these folks. They just might be diagnosed. And so I hope that you'll learn some information along the way. Today, I'm just here to tell you a little about each of these conditions because I don't think you have a lot of background or education on them in terms of your schooling. They're not as well known typically. But they are not rare. It's very important to understand these are not rare conditions. None of them are rare. In fact, they're quite common, they're just underdiagnosed. So let's talk a little about each of them and then better understand the role of an occupational therapist. And then what does the team look like and why is the team important? So let's start with hypermobile Ehlers-Danlos syndrome, HEDS. This is one of many types of EDS. It is the most common type. Yet it's the only type that does not have a gene identified. And so therefore, diagnosis is really kind of challenging because it's based on clinical assessment, if people's joints are more hypermobile or more able to move. And in addition to having these other body systems affected. So it is a connective tissue disorder. It's not just being flexible, but actually, do you have gastrointestinal or GI symptoms also? Do you have stretchy skin? Do you have soft skin? Do you have easy bruising? Do you have chronic pain? All of these kinds of things, it has to be a systemic sort of a condition, not just being flexible. That doesn't indicate a hypermobile Ehlers-Danlos or hypermobility spectrum disorder. These two diagnoses are basically interchangeable at this point. There's just some different diagnostic criteria, which is in the process of being changed. But for all intents and purposes, for you to understand, they're pretty much the same thing. In terms of who this affects, it definitely affects women more than men. And often this presents in adolescence, and we believe that's due to changes in hormones, right? And so what we often see is men might have this condition, but they don't have pain. They might be siblings. This is a genetic disorder, we believe. And so they may be related to someone who has it, but the men or the boys don't have the same degree of symptom implications. And so there is a belief that hormones are a huge piece of this. So we often see it begin in adolescence, and that's not always the case, but we often see that with a female cycle, there is often more intense periods of pain and symptoms and then lessening times. As I mentioned, diagnostic criteria, which can be found easily online. It is a clinical exam looking for hypermobility of at the wrist through whether their thumb can touch their forearm, if their pinky can go backwards more than, create a 90-degree or more than 90-degree angle there, or less than 90 degrees. Elbows, whether those elbows can hyperextend. Again, if you look straight across, and then is it able to kind of go backwards? Also, we are looking at, can they put their hands flat on the floor without their knees bent? And then just like elbows, do their knees hyperextend? So that's called the Baton scale. That's one way we look at it. And then also, do they have these secondary important factors? Is it systemic, not just are their joints more mobile? There is a diagnostic delay on average more than 10 years. This is changing, but not changing fast enough in terms of we need to be getting recognizing these patients earlier, these individuals. And so we often say when you can't connect the issues, think connective tissues. And so many times these folks are referred to all kinds of specialists, and everyone just says, you need to go to this person and this person. I don't know what to do with you. This isn't my thing. And so that can be a real challenge. And so this helps with the idea of connective tissue connects everything. The sort of mascot for this diagnosis is the zebra. And that's because in medical school, often future doctors are taught when you hear hoofbeats, think horses, not zebras, meaning think the more common thing and don't think about the rare thing. The problem is this is not rare, but it's previously been thought to be rare. And so these are the zebras. These are the people who don't get diagnosed. Nobody thinks of this diagnosis, and they're just kind of floating out around there with diagnoses like anxiety and IBS and just very vague things that aren't helpful, and they don't connect the issues, that it's a connective tissue disorder. So that's a big overview on EDS. POTS is often associated with EDS. It is a form of orthostatic intolerance, meaning when they change positions, going from laying down to standing up, or from sitting to standing, or laying to sitting, right? When they go upright, their heart rate increases dramatically. So it's as though they're working out, but all they're doing is moving to upright. And that's because gravity is kind of taking the blood down into the lower body. And typically, with a typical nervous system or autonomic nervous system, the blood vessels and the muscles constrict, the muscles contract, and they help to pump that blood back up against gravity. The problem is in these folks that doesn't happen, whether it's because the blood vessels are too stretchy or those muscles aren't kicking in well enough, or maybe there's not enough blood circulating at all. And so then they just kind of have this low volume of blood. And what we see is they get lightheaded. They feel like they're going to faint. They don't always faint. In fact, only 30% of these folks actually faint. So it's more of a feeling faint condition. However, if I feel faint, my vision might still go black. I get dizzy, I get lightheaded, nauseous, that like idea of tunnel vision. I'm going to have gastrointestinal upset. My nervous system believes I'm in fight or flight. And so I have all the same symptoms as if I were to pass out pretty much. And some of these folks do. So there's a fall component here. It is obviously, it obviously goes with hypermobile Ehlers-Danlos as well. And so therefore affects a lot more females. Even without Ehlers-Danlos though, we see this in folks who just more predominantly, we see it in women or who were female at birth. And then typically the onset is very common in the teen years, again, with those hormone shifts, but it can happen at any time. And so most commonly we see it in women of childbearing age is sort of the phrase that we use. The diagnostic criteria is this heart rate increase, and it's within 10 minutes of standing when you move from laying down to standing up or sitting up. So you can see this picture here is of what's called a tilt test, where you get strapped down to a table and they move you slowly, but at a consistent pace up into that 70 degrees position. And we watch blood pressure and heart rate. Oftentimes blood pressure drops, sometimes blood pressure goes up, but the biggest indicator is that 30 beat per minute change in heart rate. And this one, the diagnostic delay on average is between 4 to 5 years, which has gotten better. We've seen POTS a lot post-COVID. We've always known it's very common post-infection or after some sort of a viral illness. So it wasn't at all surprising that post-COVID, this would happen. A lot of long haulers experience POTS or at least orthostatic intolerance, even if it's to a lesser degree, but they still don't do well with that change to upright. It often also follows a surgery, a concussion, pregnancy, and as I mentioned, puberty is a common kind of precipitating factor, something that leads to this happened and then they developed POTS. So really a feeling faint disorder that affects that autonomic nervous system. They go into fight or flight and their body, and they can present very anxious because their heart is racing. They have heart palpitations and chest pain. And so understandably, they can be anxious. Mast cell activation syndrome is the last of the triad here. This again is a more female bias. It affects all ages. We see this a lot more in the COVID long haulers. And so it's probably this neuroimmune response. Basically, they often describe it as the nervous system just sort of goes awry and the body starts to react to things that it shouldn't react to things. Some people call it being like allergic to the world, which is a little bit of a dramatic interpretation. But despite, most people don't have anaphylaxis, most people aren't going into anaphylactic shock. However, there's all kinds of gut gastrointestinal symptoms that come with this because you have a lot of these mast cell or allergy cells in the gut, and they're just really reactive to different information that they didn't react to before or that they shouldn't react to. Diagnosis is really challenging to do because at this point, it is not very good in terms of our testing. And there's a neurologist that I work with a lot who's very smart, and he says, we're just not smart enough to figure this out yet. And so we never want to tell individuals that have this, you're making this up, or this is in your head, because they've heard that before, but more of like, we just don't know. We're just not smart enough yet, but there's clearly something going on with you. And so because of this, there's at least a 4-year diagnostic delay, probably more, because there's less research here than the other conditions. I often liken mast cell activation to where fibromyalgia was 20 or 30 years ago. People just didn't think it was a thing. We didn't understand it. We didn't know how to test for and diagnose it. But if you do biopsy the gut, you can see it's very different. There are tests that we can do. It's just a matter of the specialists, and a lot of people just don't even acknowledge that this exists. So for these folks, a lot of these common triggers will be helpful in terms of treatment, especially for occupational therapy. We love to look at the lifestyle changes, and it's not just avoiding all of these things, but really knowing and empowering individuals with this might be why you don't feel good. If you combine this plus this plus this, your bucket is full, sort of like a sensory bucket. You have all these things, and so now your body is really reacting and really sensitive. And so how do we mitigate that response or manage the amount of these kind of exacerbating factors that are happening here? And so this is the trifecta, or the triad. Sometimes we call it the terrible trifecta of this HEDS, POTS, and MCAS. And you can see those overlapping concentric circles, right? Some things are more exclusive to the one condition, but in general, we big picture see weakness, fatigue, a lot of fatigue, these almost universal fatigue in these individuals, lots of GI complaints, low blood pressure, when standing, lots of difficulty with exercise, challenges with brain fog, sort of like chemo brain, this sort of hazy, like a cloud is covering the thoughts, and they're there, but I just can't access them. So their IQ hasn't changed. They're just as smart as they were before they started having these symptoms, but it's difficulty to access information. And so hopefully you can appreciate how occupational therapy just has a huge role there, and really working through that like identity shift. And there's a lot with a lot of this. I mean, this is a huge shift in identity. And many of these individuals were athletes, especially those following head injury, concussion. It's like a very abrupt change for those people. And headaches, pain is common, heart racing, palpitations. And you can see each of these individually, like the mast cell, we see more of this flushing of the skin, hives, itchy skin, difficulty with swallowing. And then in the EDS group, you might see more of the skin implications and the easy bruising and the joint pain. And then with the POTS, you see more of that like very classic feeling faint sensation. And this is where we do a lot of vestibular rehab. But all of them really have challenges with sleep, but especially those EDS and POTS folks. So much that we can do as occupational therapists. And so really big picture here, I just want even to recognize like connecting the dots. I mean, these people have been gaslit almost universally. It's very rare to meet a patient, an individual with these conditions who has not been told it's in their head, or who has not been given the wrong diagnosis, or just completely dismissed. And so they're they've had a lot of trauma in the medical system. Some, you know, experience it different than others, and depending on their family support, even, you know, their family may have questioned if it was a psychosomatic, you know, kind of all in their head condition. So we help to connect dots, to repair, try to repair some of what the medical system has done, to say, you know, even though it feels like you have all these different diagnoses, this is why they're all coming together under this reason for this triad. And so helping to connect dots of why things are happening, connect dots of what they can do. Their symptoms feel very unpredictable day by day. And so helping with that, like, knowledge is power. You know, what is it that's causing these things so I don't feel so vulnerable to just something else getting worse? We look at the real daily life challenges, right? People need here and now. I have difficulty getting out of bed, and it's not because my legs don't work. It's because I feel lightheaded, or it's because I'm not motivated, because my depression is so bad, because I have all these diagnoses. Um, or it is my joints hurt so bad, and just moving around the world hurts. Or I have allergic reactions to stepping outside my house, and I'm scared of what I'm going to face. So we meet them where they are with practical, tangible strategies, right? What can we do? What are solutions and ideas? And it's a lot of problem solving. And man, that patient is right there with you. You don't have to have all the answers. You don't have to know everything. They're the experts. They often know more than you do. Probably almost all the time, these patients will know more if you see them in the clinic than you do about their condition, because they've been forced to learn about it. They are so educated on it, and they've had to learn. Many of them had to find it out for themselves to get a doctor to diagnose them, because their doctors couldn't figure it out. And so ultimately, listen to the human in front of you. You don't have to have all the answers. If they don't know how to help their fatigue, then you're going to work on energy conservation, energy management strategies, and pacing. And you do, you know, your own research, but you're going to listen to the human. You're going to be there for them, and you're going to hold space for just how the medical system has harmed them, and how we bridge that gap in healthcare of really being able to see their whole person, the spiritual, physical, cognitive, emotional, and sensory components. And that's just so powerful. So I hope you're excited for becoming an OT. And then not only us, right? We have our role, but man, we need a team. And unfortunately, there often isn't a team. I'm often working in a silo when I work with these individuals, because we don't have enough providers who know anything about this stuff. But so working with the client first and foremost as the number one person on the team with you. And then in terms of IPE, really reaching out, families too. They've often done a lot of their own research and helping to educate them if they're not on board and understanding what's going on. But then the team, right? Really leaning on those PAs, those NPs, the medical providers to really understand medication. And we can even recommend medication if they don't have as much knowledge on it. Recommend it to the team, not to the patient. But I have definitely told medical providers before, look, I'm hearing these symptoms. I'm curious, do you think this sort of mechanism would help in terms of medication? And they often appreciate it, because I know a lot about this condition. Leaning on our social work colleagues, and just psychology in general to really understand, man, we need help with resources in the community, and more of that psychological, psychosocial support. Physical therapy, oh man, I have fortunately a great colleague in the office who I work with, and she does a lot of vestibular rehab and a lot of strengthening and exposure to movement that isn't harmful. You know, having to rebuild that trust. There's often fear of exercising. Understandably, they've been hurt by physical therapists in the past who've told them they know how to help them, and they don't use a hypermobile treatment plan. They don't know what to do. And so really helping to restore trust and bridging that with your team is so helpful. There's so many other folks that we can talk about this with. You know, dietitians are great with the sodium and the fluid with POTS. We use compression garments with POTS, and the allergists obviously we need for mast activation, as well as the like lifestyle redesign pieces, and just really helping to look at that whole big picture view of serving these individuals. So I want you to know today, walking away from this, that these are complex individuals, and they have multiple areas of life affected. Even if you ask, how do you do showering? How do you do brushing your teeth? They might on the surface say it's okay, but then you dig deeper and you realize, well, brushing my teeth's okay, but it's really hard to do because I don't get good sleep and standing is really hard. And it's not a part of my routine and I'm neurodivergent. And so I forget. And okay, well, how do we break down this routine? How do we get you a chair in there? And so it's just incredible when you start to peel back the layers and we open up a safe space for them. They frequently present with the psychosocial challenges and lots of medical trauma. And so just keep that in mind, working to rebuild trust, not being too urgent to change something or get in there, but really just to understand and process with them and meet them where they are. There is very limited OT research and protocols. I'm proud to have contributed to that, but I'm embarrassed with how little our field has. However, know that there's a lot more coming out, even by the time you get out of school. And resources, you can use resources from other diagnoses. It doesn't matter. Fatigue is fatigue. And so, how do we treat that? Sleep issues are sleep issues. What do we do for that? And overall, it's a very grateful population for what you can offer. And so just want you to know how rewarding it can be to work with someone who says, no one has ever listened to me before the way you have. Or if I say, you're not broken, we just don't understand it all yet. And we're going to try and put the puzzle pieces together. And they look at me like I'm crazy, like I'm definitely broken. And it's just a beautiful thing to be able to be present with someone through some really hard things that no one else has been present with them for. So I'm grateful that you all are going to attend this IPE day just for the education experience of working with the other professions. And I'm really excited for you to get to learn about this patient population and the potential impact that it's going to have in terms of when you get out of the field and into the field and are able to really make a difference in people's lives. So enjoy. I'm here and happy to answer questions and just chat with you more if this is something of interest. Even a few years down the road when you're practicing, reach out. And it's just excited for you all to experience this day. All right, take care.